So als nächstes.
Next, Thorsten Liem, and he will talk about the high cervical dural relations. Thank you. I will talk about the topographic aspects and not that much about the therapeutic aspects. This will be taught in the workshops. So Jane has shown wonderfully what kind of research she's done on the dog, and I'm going to show you my research on myself. So I did an awful lot of training. I'm normal here. I'm standing. You are not normal because you're sitting. And for you to be able to become a bit more healthy and stay healthy, I'll ask you to get up.
Ja. Ja. Und jetzt setzen Sie sich hin, ohne auf.
And now, sit down without placing your bum on the seat. And stay like that for the next 20 minutes. We'll do it together, okay? So the positive myokines can take full force. Don't sit down on the seat. So, I will talk about Dura, and what I want to say about that is that there are other aspects apart from the Dura that have got to do with mechanical aspects, and also the pia and arachnoidea. And here you see the Dura. Are you still all right? And here you see such a fibrous elastic sheath provides protection for the spinal cord and the CSF. This is done by the Dura. And there's the pressure of the CSF to push it outside. And this has nothing to do, or this has a lot to do with the musculoskeletal effects, particularly of the upper trunk, respiratory, pulsatory factors, and they bring about elongation. And here you see there are longitudinal fibers, and they see to the fibers. You're getting weaker in your muscles, and you see these forces here slightly different in the upper part, and therefore the fiber is different. It's more horizontal. We're going to see that a little bit later. Only 2 more minutes. And the arterial vascularization of the dura. I mean, as osteopaths, we are talking about relationships all the time, and the relation here between the different tissues. And here we've got the anterior artery here. This is the anterior spinal artery and also the posterior spinal artery. And when there are changes in these arteries, we understand that there is a connection to the. Okay, I understand you're getting tired, so why don't you sit down again? So they are in relationship with the neck and with the chewing activity and the facial parts, and there's a hypothesis this can bring about tension headache. And what is interesting here is to see how it all works. So there are mechanical stimuli like whiplash and also neurogenic and chemical factors, and they mean that the fine and soft vessels are subjected to a spasm, and that can last for hours, weeks, months. And what is important for us is that these spasms can be referred to the vessels into the brain proper. And therefore, it is of essential importance to carry out treatment on these structures as well. We've got all sorts of different approaches. Whether they work as we want them to work, we cannot say, but we can take the vertebralis artery and change the sliding feature, and also the arteriovertebralis gives the structures the respective supply of whatever they need up to atlas and axis, and then it goes through the dura mater and then also the teeth of the ligamentum. And this is also influenced by various structures like the anterior or the vertebral venous plexus, and this is structures that we need to take into consideration if we want to influence the system around the dura mater. And this, of course, is of importance. And apart from that, this is a fast thrust. This is less than 200 milliseconds, meaning that such a spasm can be resolved. So this is a highly cervical short lever thrust technique, which really makes sense in this area. So you see the chain that we are seeing here is mechanical stimuli, sensitization, then hypersympatheticus, chemical stimulus, and then the vascular spasm. And therefore, this is one more thing which we need to mention when we treat the dura as regards to vascularization. And here we are talking about the treatment of the sympathetic tonus in the upper part. We need to test it and we need to bring it down in order to be successful in our work. And we will talk about the techniques later. And the veins are very important as well, because if there is a disc prolapse, then there is the canal getting narrowed, tighter because of this disc. But very often there is a plexus venous, and then, of course, we can try and bring about a drainage of the structure with the help of our fingers in this region of the venous plexus. And we will talk about that a little bit later, because there is also one other indication, and this is subject of a work of research which is not yet published. And innervation of the dura is also very interesting. So there is the sinus vertebralis nerve, and here it is very important that here we are not talking about here we have only got the nerve neurosis here stimulating again chemical, mechanical, and thermal stimuli, and this then means that there is pain sensation and brings about wrong innervation. And there it's also very important to see that the nerve cannot slide that well any longer, and we have to improve the situation as osteopaths. So, for example, we can take the second layer of the hypodermis tested, and wonderful work by Bonash, for example, where the vagus can be activated in the left ear, and that, of course, has got a bearing as regards the spinal trigeminal nerve, because that will converge the information and also the pace information from the dura mater. And what is also very important is that the dura has got multi-segmental innervation, so it is not segmentally located, but it will affect several segments thereof. So here you see ultrastructure. I will not talk about that. It's interesting, but not now. So here the orientation of the fibers. So they are collagenous fibers, and they go into all sorts of different directions, particularly complex in the upper part. And then in the dura, we have got a lamina from different laminae, as you can tell, and also elastic fibers in the posterior part, double as much as in the anterior, because the movement towards the anterior side is much more pronounced. And this dura here is suspended just like, what you call it, just like a springy belt in the spinal nerve. And any rigidity or restriction to slidability in the spinal nerve will bring about a reason that the slidability in the dura is slightly impaired. And you can see it very well here. This is French. So what you see here is the movability, even if this is a fetus. You can now choose what you want. So this Dr. Dombad, and he participated in course from Wallerframlen, and he was a plastic surgeon, and now he's become a video maker because he did the video thereof. And what we can see as well here is that the movement of the spinal cord and the spinal nerves is dependent on the movement of the neck. And here's the inflection. We will have kind of a folding of the spinal cord and the nerves, and in extension there is an unfolding. And we can, of course, also try to palpate that with our hands, and we are never really sure whether we feel what we palpate. And the best story to explain what we're doing is the one where there is somebody in the street and he gets lost in Paris and wants to get a drink, and he sees a table, and there is a woman sitting there, and he gets there, and they get chatting, and then they go for a dance, and they have a drink, and then they have another drink, and this being Paris, they end up in the same room and bed, and then the lady asks him, "Are you an osteopath?" And he says, "Well, how do you know? Isn't it that you are a very famous osteopath?" And he says, "Yes, okay." And then why do you ask? Well, I didn't feel anything. Okay, we are doing great many things where we really don't know whether we're doing the right thing, because our prefrontal cortex has got neurons that take care of themselves and ourselves, and if we start palpating, we are flooded by our own biased attitude, and we interpret things into what our hands read. And they see there is the interspinal ligaments, and they are not outside, but they are in the vertebral duct itself, and they connect the dura mater with the bone, and they have got different influences. And the strongest is if you flex the head and extend the neck, that has got a cranial tension on the ligamentum interspinale. And here again, we can try to approach it like that. Then there are also adhesions here in the intervertebral foramen, and they would be rather fixed, and they fix the outgoing nerves, and that might also be a reason why this cannot escape if there is a disc prolapse. And here you see the epidural space, lots of adipose tissue with venous plexus and lymphatic structures. And again, there are relationships established here to the dura, and we are going to explore that a little bit later as well. And what you would normally describe in the osteopathic or books is this adhesion here, C0, C1 is very often forgotten by Muldoon. I'm not sure why. C2 to 3 and C1 is most fixated, and going down to the coccyx bone. And you see the specificities are to be discussed now. And here we see the connection here to the ligamentum denticulatum. And you see this is different upstairs, or in the upper and caudally, it has got a different orientation. And this is subject to change with the biomechanical demands. For example, in flexion here, this goes against these teeth, and in extension, they approach each other. Again, a biomechanical transfer between the spinal cord and the dura. So latest and recent studies had a look at these connections, relations. For example, the vertebral dural ligament being shown here, and this was shown here, the rotational movement, and this goes to show how it is all being transferred to the dura and then is postponed laterally. And here again, we can make a distinction here between the triple dural ligament. So there is a cranial part, which is the atlanto part, and then to be named ligament. So that was nice. They did not take their own one, but own name, but said this is the to be named ligament, and this is the axial part, and this goes towards the axis. And they have got a very strong connection here in the posterior part of the dura mater, comparison to the posterior part of the atlas and the axis. And let's have a look a bit closer here, because they have got interesting clinical pictures as well and consequences here. So here we see the nuchal ligament here, and the connection thereof, and then the interspace between C1 and C2, and this goes into the dura where it is being anchored. Again, rotational movements are being transferred via the nuchal ligament, also in the dural space, and this might again have consequences as regards the development of a headache. So here then the dural bridges, MDBs, have been examined for some time, and they are of importance here, functional importance. So let's have a look at this one here. Here we've got a very clear relation that you'd find earliest, and this here is the rectus capitis posterior minor muscle. And here you see small fibers, and they go along the structure here, and this is where they come together and pull towards the front. And then it continues here close to the atlanto-occipital interstitium, and then it converges to thicker bundles, and then this means that this goes into this structure here through the membrana or the posterior atlanto-occipital membrane, and then we'll see connection with the dura. So you see these relations here go to show the path of the myodural bridges. And when we try to make a living with all that knowledge, it's very important to really focus and try to find whether there are tensions there in one way or other, whether we can palpate them and then dissolve them. Release them. And then there's also the rectus capitis posterior, inferior, and major, and then they come together into this range here. And this here is in the converging field in the ventral dural ligament, and then it comes together in this structure here. So them three coming together between the C1 and C2, and or three, not two, three. And this was investigated in anatomical papers as well. Different hypotheses discussed. For example, that on the basis of these muscles, we will have something like an invagination and a pressure on the spinal cord, that the pressure there is to be prevented. And I mean, there we've got many proprioceptors, and this is important for the general control and also the integrity of the subarachnoidal space, and also the cisterns that come in, and then also the control of the CSF, important when we're talking about tension headache, and then also the dural pain syndrome, because the hypothesis was that if there is a tension in the suboccipital muscles, this might propagate to the dural structure, and that would then mean that there is the nucleus spinalis that registers, and that of course gives rise to an unspecific pain sensation. And then also the suboccipital muscles, they can pull quite mightily on the dura, as you can tell. And what is also quite interesting, a study that has not yet been published, a whiplash can also have or can be triggered by a head movement, so that the canal of the is narrowed, and then there are impulsive pressure changes also outside the dura mater spinalis in the venous blood supply system and within the dura spinalis in the cerebrospinal field, and this fluid will then interact with the dorsal ganglion. And there we had quite interesting studies that said that pulling and pressing processes would happen, and the pulling processes are much more significant because they have got a negative pressure on the central ganglion, and that will generate symptoms or can generate symptoms. And maybe this is also a reason why we should really do something to improve the outflow of the venous blood. And then it's also quite interesting to have a look at C2. C1, C2, C2, C3, C71 via the ligamentum flavum. And here we might have the influence of something which comes along as a myopathy. And then finally, I would like to talk about a more differentiated representation of the bony structures to the dura mater spinalis. So here, for example, the foramen magnum, and then here on the articulatio atlanto-occipitalis, and then also between C1, C2 in the ligamentum longitudinalum posterium and also the tentorium, and then also the ligamentum atlantis, transversum atlantis, I should say, and then finally also on the arcus of C1 and C2, and the ligamenti flava. And this here is a representation of how pronounced, particularly in the embryo, this movement is transferred to the dural sector. So minute movements here, it's all being transferred. And then we have got the mechanism here, and there is too strong a fixation or fibrotization. This will have a bearing on the slidability of the dura in this local region. And that means here, on the basis of these adhesions, we can come back to what Milan suggests, to go for 3 levels. So in the upper part, the upper level, and the middle level, and the lower level, if you can call it that. And of course, we can try and approach this by palpation. And I was a bit fast in my presentation. I hope you could follow. Thank you very much.